It doesn't hurt every now and then when we have these conversations to talk about the alertness with which every single Kenyan must look into processes that are happening, that you must greet this thing with alertness. It doesn't matter what it is that we're talking about, that you have to be woke to the realities of the times. And that could apply across board in anything. And we've just come off a political conversation and we're going into a health one. So even an alertness about that particular situation then is demanded of us as we have this conversation. And so we're moving a little bit this hour, and we're looking into the SHA question. Dr. Joseph Kariuki, who is the Vice Chairman of the Rural and Urban Private Hospitals Association, otherwise known as RUFA, is in the hot seat with us. Good morning.
Good morning.
How are you doing?
Great.
Yes?
Awesome to be here this morning.
Well, thank you for doing this with us this morning. So let's talk about health, shall we? Absolutely necessary for us to look into some of these things because the questions continue to swirl. And I've said, you know what? There's the accusation of being perennially negative about this health system. Mm-hmm. But then my question comes in and I say, if we have to keep asking questions all the time and have to continue complaining, then surely there's a problem somewhere. But let's look into some of these things today. Sure. Before we do that, as you know, we go around the African continent every week. We come back from a particular country. We come back with the goodies. We also come back with the proverbs and the things that they go by. This week we're in Eswatini, the Kingdom of Eswatini, surrounded by South Africa. Very still extremely cultural, but still modern in the sense that, you know, the monarchy does affects the national government. The national government takes the monarchy into consideration as well, but they still keep things moving. The proverb for today, which we'd love to get your interpretation on: a roaring lion kills no game. A roaring lion kills no game. What would you think about it?
Thank you. Quite an interesting one. Mm-hmm. But from where I sit, if we have a lion that is roaring in the wilderness, it will scare every of the prey around. And so at the end of the day, it will end up not killing any or getting any prey because of the noise that it has made all around. Yeah.
I'm telling you, the human brain is a fascinating thing because here we are. On one side, you would say that the lion, if it's wasting all its time making all this noise, then it will lose its food. Mm-hmm. But then you look at the literal sense of it, that truly you roar the whole time and you're making such a sound in the wilderness or the forest or whatever that all your prey essentially will run away. Mm-hmm. Sure. So, I mean, it's just great that we can see both sides of that interpretation. So thank you for that. And that we can learn many lessons from one thing. All right. Shall we? Sure. Because getting the system to work for Mwananchi, the SHA question. In the recent past, Dr. Kariuki, we've seen the stories, and I do get it that there's a lot of propaganda as well out there. People just wake up in the morning and say, oh, SHA isn't working. But then we had a Dear Mr. President session a couple of weeks ago, and we said, Dear Mr. President, do not listen to the folks who are around you who are telling you that it is working because they want to, do it for political reasons. In the same breath, do not also listen to the people who are on the other side of you, polarized politically, who are telling you that it is not working. Don't listen to those people. Listen, dear Mr. President, to the people who are walking into the four walls of medical facilities and are not able to get services. Those are the people that you should listen to. Don't listen to your political rivals or your political allies. Listen to the Kenyan who is saying, I have a child with special needs. In Mombasa, I went to the hospital, Coast General Hospital, and they told me that I have a card that expires, my service expires in October. But for some reason, I couldn't access for my son. So they asked me to pay up for a year again. And so I paid the 7,290 shillings. That's what it is for about a year. I paid that. And still, I could not access the services. And they said, okay, when you come to hospital, because the situation that her son has, he must be on an injection every month to kind of keep things at an equilibrium. So the 2,500 shillings for that shot, still, she has to pay out of her pocket. And she does this because she wants her son to be well. the system should work, but it does not. And I say that the president, those are the people that you need to be listening to, because it is a real concern. And I'm taking a little bit of time with it so that we can set the stage for this conversation. Or listen to the gentleman who goes to hospital here in Nairobi and says, I am a cancer patient. I was in remission, but I still see some of these things coming back. I went and they told me that, again, my cover has expired, but I know I still have 6 months left on this thing before I have to pay again. I don't have the money to pay again. So when I go for a checkup, I lie to my doctor about my symptoms so that maybe I'll just get a little bit for pain. And then I will pay for that because that is what I can afford. Then I can go home and I continue to manage the situation. Dr. Kariuki, those are the real stories. Those are the ones. And truth be told, there are those who go to hospital and they get treated and they come. They are okay and SHA works for them. But we're saying if across board, we still have these horror stories 2 years down the line of a new system. Why is it not working for the mwananchi from your perspective? And I took a little bit of time to build that, but I thought it was necessary to do that.
And you have actually done a great job because you have painted a picture of what is actually on the ground. That is what we face every day when we wake up and go to work. And almost 2 years into SHA, it will be unfair for us to answer the question in one word, whether SHA works or not. By now, we are supposed to have seen every facet of SHA and decide which one is working, which one is not. First of all, SHA is a system. It runs from where the patient, registers and pays money, and the benefits are triggered, coming to the hospital, claims management, all that. So it's a system. It will be unfair for us to say that SHA either is not working or it's working, because in a line, there is some areas that SHA is doing very well. There are some areas that it's failing. And so that is why being into it almost 2 years, we can't just put a word and say it's a yes or a no. What we do is what we do as an association of hospitals, carrying out a survey, an extensive survey, and point out several areas within the process and say this is working well, this is not working well, and then give an average score. So for now, we can say SHA is still acting below expectation. Okay. But we cannot give it a 0 and we cannot give it 100%. Yes.
And I agree. I don't know where the below expectation places it, between 0 and 9. But it is true. There is a public outcry on how the SHA is working. There are areas we hear of exemplary coverage in terms of bills and ensuring the service provision was efficient and effective. And there are also other quarters largely where you hear complaints. Unfortunately, this is a conversation that revolves around a system that ought to be safeguarding life. It's not about clothing or even not that it's a better comparative, but it's not about even education. It's about people who are ailing, who are sick, who are just minutes away or a level of care away from losing their life or their condition exacerbating. So these complaints cannot just be statistics and numbers. It is okay, yes, we'll do a survey as an association to try and identify the gaps and see how they can be filled. But when you look across board, the standard practice of universal health coverage, should it be laden with so many gaps 2 years later?
Absolutely not. And I can tell you a few problems that we are facing.
Right.
First of all, like you say, 2 years is a long period of time to keep on having the same conversation all through. we do service, like I've mentioned.
Right.
And when we do this service, they don't end with us. We share it with them. And we tell them from the provider side of view, this is how we are seeing it. If you can look at this, you can look at this, amend here, change here, see how you can improve here, then the system will run well. Apparently, we do not have a SHA leadership or the MOH leadership that listens. It is either their way or the highway. We have made this point very clear that for you to have a system that is working for all, you need to have these three parties on the table. That is the payer, SHA.
Right.
That is a provider,
The hospital.
the hospital, the healthcare
the facilities, yes.
and the patient. When you have these three people on the table, you can't miss on a solution, because universal healthcare surrounds around these three parties. And it so happened that the leadership of MOH doesn't listen. And many times when there is a public outcry, they run to the patient and they say, we had a conversation with them, and this is what they are saying. They have left the other party out. And this being, to make it a complete circle that works, all these three parties ought to be on the table and speaking the same thing, agreeing on the same direction. It is in the Bible, two cannot walk together unless they agree. Yeah. So if one party is left behind,
Right.
then you will not get to your destination as expected.
And since in practice you're not being listened to, your input is not warranted, and I would assume the same goes for the patient. So it means it's only the payer who is doing the talking. What then room do we have for improvement? Because you look around and see that, one, health is supposed to be a public good. You should not discriminate whether you can afford it or not. I think when you look at a pay slip, you're not charged extra to pay a judge, to pay a teacher, to pay a policeman. Why am I charged extra to pay a doctor? It should be a public good. Sure. It should be covered by my tax.
True.
So, the profiling, and that is where the double taxation comes in. But by and large, as we yearn to correct that, because in my opinion, I feel there has to be what you call a free healthcare or public-funded healthcare, whereby you just need to be identified as a Kenyan, and you access the service. The tax ought to take care of that. That is one. On the other hand, I also believe that the existence of a lot of the private sector in terms of healthcare is because of the failed public system.
Exactly.
Do you opine the same?
Yeah, I agree, actually, to a great extent what you are saying. And I'm a lover of John Maxwell books and leadership. And one of the common phrases that he says, it all rises and falls at the leadership. And I think that's where we ought to focus. If the patient has given you feedback, the provider has given you feedback, why are you stuck? And for now, we should expect that 2 years down the line, SHA and MOH should have known that what these people are saying have sense. For example, 2 days ago, they brought back Linda Mama. Just 2 days ago. And for all this time, we've been making noise. Why did we pull out this thing? Yeah? And this is what has been helping our mothers all through in the previous regime and part of this regime. This is a critical component in the maternal health. We need it back. And nobody was listening. Until now, the outcry there was so much noise. And silently, they just produce, a circular, or is it a regulation to allow it to come back. So what we need to look at here, and probably make our noise in this direction, that the MOH leadership ought to listen. I'll give you an example that happened the other day. There was a big hue and cry about the teachers scheme when they joined the POMF.
Yes.
And the teachers had all the problem, and they were making noise all over. And when they come to the hospital, sure enough, we told them we are not able to help you in this situation. And when they made noise and they wanted to pull out of POMF, they are taken to Naivasha. The meeting happens in Naivasha between the payer or government and the teachers, the patient. The providers are not there. They come out with an agreement that now we have agreed that for every outpatient visit, we will provide 10,000 shillings for you to be treated, so that we tell these facilities no co-payment at all. And the provider is not on the table.
I'm sorry, I just need to understand. I'm just trying to look here. Okay, so as a patient going into, because these are the processes you must understand, because they come out into the public and it sounds like something totally different. As a patient under SHA, there's also the issue of people who have alternate insurance. But now under SHA, I go to hospital and whatever I'm doing, labs, whatever, should all be covered for if I'm going to get a prescription after diagnosis, get medicine, right? But if the facility, because it's almost like an arrears system. You pay, or rather you get the service, and then the facility will then claim the money later, isn't it? Okay.
Sure.
Now, in the event that there's no pool or there's no assurance that you get, then that's why a lot of people are being told today, we can't do it here because we have not received money. That's the truth.
Sure.
That why they're being sent away is because SHA doesn't work here. It works. But the problem is the pool is not available. They've not paid what we've done in the past. And the likelihood of them paying in the future then is dim. So where does this arrangement come? Because the people who are providing the service is the hospital. When I go to hospital, it's not the Ministry of Health. I'm going to get a service. So when you do the triage and all of this, labs, etc., it is the facility that is providing the service. So when you're going to talk about how we're going to fix this and give you 10,000 shillings, why would you not then have the facility there to tell you, okay, sure, we can do this, and with 10,000 bob, we can then offer you dialysis, we can offer you, treatment and procedure. Why would you not bring in the person who is giving you the service?
Very interesting. And apparently I can't answer that question, because we are very much willing as providers to be on the table. Our discussion today is how can we make SHA work for Mwananchi? That is a conversation we would very much want to have every day, because it is easier for us. It is easy for us to offer service in an environment where these things are working. So, and the reason for our surveys, our mini survey, is to give this word so that we can make this thing work. You mentioned a very good thing. Why are they not paying the hospitals?
Yes.
That's a question that we always ask. And but from our understanding, there are underlying issues. Because for once, to say the truth, SHA has not been able to collect enough money to pay the amount of claims that are being generated.
Okay.
That's one of the reasons.
Are you saying they undercollect?
Yeah, they undercollect. Yeah. They undercollect. In fact, the last amount of money that NHIF collected before they closed, SHA has never attained that.
But we lost 11 billion. I'm just saying, we lost 11 billion the other day. Just the other day.
Yeah.
And before that, we invested 104 billion, the transition from NHIF to SHA. Are you saying that you as the partners, or rather, what was the essence then of transitioning if one, we're not able to offer safeguards? Because I feel we lose the conversation when we start talking about money and figures. I think the focus, in my opinion, ought to be more about the processes, like the pre-authorization. There's a limit on how much SHA will pay for you and have a certain condition and many visits you could make to the hospital. There's also the variation when you go to a higher level of a facility than, a dispensary. I think these are the processes and procedures that we ought to focus on, so that you now, as a provider of the service, you're able to come and say, this process makes it difficult for us to meet again the medical care that this person needs. Because payment or no payment, that is the after the provision of the service. But in this process, like the 104 billion that was meant to ensure we have a more streamlined transition. And also there was the FIF, Facility Improvement Fund.
Yes.
Where does what happens? I don't even want to ask about the money, but what is the impact of those resources having been deployed to the facilities?
You've answered a good question. And that's why I said earlier that SHA, almost 2 years in the system, it acts below expectation.
Right.
All those are reasons why it is below expectation. And a number of things. Let's talk about the processes that you have said. We have not been able to iron out the processes. Despite having a 104 billion system,
Right.
we've not been able to iron out this system. And you realize that without systems, you can't have good outcomes, because garbage in, garbage out. We need to have that conversation, and we are behind schedule, by the way. 2 years is a long time to just be talking about system. This is what we should be doing before even SHA came into place. Now, when the processes are aligned, what happens is that it makes it easy for the patient and for the provider and even to the payer. But when we still have this issue, the processes are not running. We have the pre-authorization that is not going through. We have the amount of claims that are rejected because of systems. Because there are some claims that have been rejected because you are not able to attach a document, yet it is the system that is not providing you the provision to attach. You find a delivery has happened in the hospital, and the only thing that you have to upload is a birth notification and an invoice. But they ask you, we are rejecting this claim because you did not attach a discharge summary. Where would you have attached? So we still have problem with the processes. And this is now, I think, what we should have ironed out before we get into the
So it's a system issue, and the 104 billion shillings essentially was to provide a foolproof system where all of these things that you're talking about should then run without an issue, without a hitch. You shouldn't have these bugs whereby you need to attach something in order for a claim to be filled or paid, but then you can't do that because you can't attach. I mean, it's dealing with some mundane issues that even shouldn't come up. Because you should not spend 104 billion shillings and then have issues such as that.
Absolutely.
Neither should I be sitting at my desk at 11 o'clock in the morning and tap into my SHA account and find that I had a procedure this morning by a particular doctor and I was charged a certain amount of money while sitting in my office. These are things that are happening to people. People who have sat in this room last week told us about, excuse me, how can I be sitting where I am? And according to the system, I've just had a procedure in hospital. So obviously, such things don't work. That's why we see the things where one woman has given birth 4 times in a year, or that one person has had open heart surgery, I don't know how many times in a very short period of time. Those mistakes are too large to be happening in a system that is meant to be foolproof by virtue of the amount of money you spent on it. We shouldn't. There are some things we shouldn't be talking about, and I think that's just there's no answer that's required for that. But where an answer is required is, can we, if we're to look and say where would the thing fall, if we're looking for a place where some issue could be, are there enough people who have been registered for SHA that are making their payments for this money to make sense? Because at the end of the day, it does come down to that. Are there enough people who have paid up for the entire pool now to access the service?
Very interesting discussion about the 104, because we only hear it is there. Yeah, because if it is really there, like you asked, we shouldn't be having this kind of issues.
No, you should be able to attach a document in a summary. If you spend 104 billion shillings on it, the thing better be like Fort Knox. It should be able to work.
It should be able to work.
Yeah.
That's why I say I doubt whether it's there, because if it is not doing those basics, it is a big flaw. And remember again, there is,
as an association, why are you not involved in the rollout of SHA? Why are you not involved in the development and the rollout of SHA?
My brother, we were involved just like any other member of the public through the public participation. We attended virtually every meeting for public participation to give our views and, the way we look at things from this end. But whether those ideas were taken or not is a discussion. Because we give, and like we say, every time we share with these people the service and the voice of the people. Why they are not doing, that's another thing. We can't explain from our end. But we said we will never get tired of doing good. We will keep on giving our suggestion on how to improve this system.
So then, in your opinion, instead of trying to, in the words of one of our listeners, painting a sinking boat, because that seems to be what we're doing. Because we know one day, the 104 billion, you say it was a mere rhetoric, then you lose 11 billion. And then, on the other hand, you hear of ghost hospitals that actually receive money, And money, there's a paper trail. You cannot lose money this day and age.
In the same 104 billion system?
Yes. That was meant to be foolproof. On the same breath, you hear people who are busy working, and yet apparently they're in some surgery, they're undergoing some surgery, and the SHA that does not work pays for them fully. That's the irony. The people who are paid for, incognito, it is paid fully.
Yeah.
But those who deserve the service, they cannot even get the pre-authorization.
Nope.
And we have had instances where people have lost their lives because they could not be admitted to a certain procedure due to delayed or lack of pre-authorization. So, do we continue trying to paint this sinking boat? Or should we, as a nation now, deliberately work towards a public-funded healthcare, whereby all these deductions are done away with? The same way I was saying earlier, you're not deducted extra for a cop, for a judge, Then you, as the providers of the service, will be dealt with at the policy level, and the disbursement or the, how you claim back the resources is purely at a policy level. But the patients will not need to pay a single cent. They just need to present themselves, identify themselves, and then the system will acknowledge their medical records, and they get attended to. Should that be the direction we go?
Yeah, like you have said, it is not prudent, it is not economically viable to continue painting a sinking ship. We need to come out of our slumber and purpose that if we brought in this SHA to help us attain UHC, to help us meet the medical needs of our people, then it is time. We need to sit down soberly and look at this thing. Personal issues aside, like my sister said earlier, that they are perennial, naysayers of SHA. And there are those who make noise in funerals and other places saying it is working. We need to bring our thoughts together and say, politics aside, side shows aside, let's have a conversation, a national conversation about health. And for us to succeed, let's have the payer, the patient, and the provider on the table. And we can even bring in many other. There are many stakeholders in health, so that every voice can be heard. And then we pull down our ego, we pull down, statistics that doesn't work. We come out and agree that if we had a 104 billion system with AI integrated in it, we shouldn't be talking about this thing right now. I can tell you, even AI, go to ChatGPT on your phone, and when you ask something, it will give a disclaimer down there and say, you need to verify this information. AI is not absolute truth. So it can't be that when AI is mentioned, all of us should keep quiet. No, it doesn't go like that. By the way, the NHIF system that we used to have then did not have AI. And we did not find this magnitude of losses, especially in under a year, 11 billion. You find these ghost hospitals like this. Yeah, there was medical fraud. But if you are to look at it, it maybe did not go above 10%.
So what can Kenyans do? Because we are the majority, we are the shareholders actually. We contract you to offer a service because it's paid for by our taxes. Yeah. We employ people to manage that policy and streamline procedures in terms of practice That's why we have a CS. He's an employee of Kenyans, courtesy of our tax. The same tax that is paying for the services of those who need the medical attention. So we own this thing. It is ours. What can Kenyans do?
Now, Kenyans should demand their right. It is a constitutional right to get quality healthcare. It's in the constitution. The teachers are doing it very well. That's why they are taken to Naivasha and wherever to discuss this thing. That's why there is a conversation every day about them. But the mwananchi down there, pale kwa ground, is not doing anything or is not doing something enough. From our provider side of view, that's why we are here in a conversation like this, because a teacher somewhere or a civil servant or a Kenyan went to a hospital and they were denied treatment. And that is how we are making the discussion come alive. We want everybody to speak about it, the media, every stakeholder, the doctors to come out clean. Sometimes I personally get disappointed by these doctors, these surgeons, because they are the ones that majority or much of this money is owed to them. But you know what they happen? They have no time to engage in other discussion other than their practice. That's a problem. Because when they come to my facility and they perform a surgery, it is my responsibility to pay them. I pay the surgeon, I pay the anesthetist, and they go, so they don't feel the pinch. I am left there with the patient for 3, 4, 5 days, taking care of them, pain management, and all that. And then me, I'm not compensated. So it is me who makes noise, but the surgeon is comfortable. The anesthetist is comfortable. The Kenyan who came to the facility and was operated on and went home is comfortable. They are not speaking. Kenyans need to come out and speak out and say, it is time, we need this thing. And we as the providers are pushing the conversation to them. When they come, they say, you either co-pay or there is no service for you, go to any government facility around.
Co-pay is, just for purposes of understanding, this co-pay, what is it?
Co-pay is when a mother comes maybe for delivery, SHA will reimburse 10,000 for normal delivery. We will ask this mother either pay an additional 3,000. Just in case that money doesn't come, at least I'm cushioned.
Yeah.
As a facility, you're cushioned.
Yes.
But in terms of fairness in provision of healthcare as provided for by the Constitution, is co-paying a standard practice?
The SHA Act allows co-pay. The only caveat is the patient or the client should consent. So
can they decline? If they cannot afford it, what happens?
Yeah, if they cannot afford, you make a choice. Either to do a CSR or to refer them to the next available.
But can we look at that SHA Act? Because I'm still trying to understand. And I don't know, was I asleep when we were told very clearly that this universal health coverage meant that because of a premium that you pay and the responsibility that government takes, that means you go to a medical facility, you get treatment, you leave without having to pay an extra coin based on the fact that you have paid your premium. I mean, it's sad that we have to go back to this, but I just want to understand, unless maybe I missed something. But this is what we were told, that UHC means that you won't have to. So if we're saying that the SHA Act provides for co-pay, does that mean that there was already a foreseen situation whereby this foundation that everybody understood was to be the case would then not be possible?
Now, we need to understand that SHA provides service in different stages.
Yes.
One is the PHC,
yes,
the primary healthcare. This is where we are told that the moment you register, you can walk in and walk out in a level 2, 3 and select level 4 and be treated and go.
Is that the case?
It's not the case.
It's not.
Because this PHC is public funded, is exchequer funded. And many times we found that Parliament has not appropriated enough money.
So the money is not there.
Yeah, the money is not there. So even if you walk in, what will you be consuming?
Okay, so let's get that clear.
Yeah.
The first level is the PHC. You should be able, because it's exchequer funded, we are assuming that Treasury puts in an amount of money at this level, and the money should be there in this pool.
Sure.
All right. Where they get the money from is budgeted. Like now, we're going into budget. It's budgeted health. Your budget comes and we say, for sure, at the PHC level, we need 1 billion shillings. So the thought is that 1 billion shillings should be there, so that when I go and I have a fever, whatever you do the thing, it should come out of that money. But we are saying that Treasury, more often than not, does not put that money there.
Sure.
All right, clear.
Yeah.
Next.
The second one is SHIF, where we contribute 2.75 of our salary. And that money goes into the SHIF kitty, so that when you go to the hospital, then that money works for you. There is a benefit package that is cut out for that. Now, this is now where we are saying you can go to the hospital and choose that my cover maybe allows me in a general ward. And you want to go to a private.
Yes.
So you will be asked to cover for the extra. Yeah, that's where the co-payment is coming. And that's why we are saying you have to give consent. Yeah, so when you sign consent, wherever room you want me to take you, I will take you.
So the co-pay is on your personal preferences here?
Yes, or something that you want covered that is not within your benefit package.
Okay.
Yes.
Okay. Then I it's quite symbolic. But all the more, it's what we have. My question then is to the provider, the facilities.
Yes.
Delayed payment, delayed pre-authorization, sometimes disputed claims whereby you have a genuine claim, but then the authority finds it in itself to say that we are not going to reimburse you or pay you for this.
Sure.
And of course, sometimes low intake of the service from a facility, because if you've had issues with attending to patients because of share compliance, some patients will opt to go to another facility and not come to this facility.
True.
So among many other factors, how are these factors affecting the quality of the provision of care from the facilities?
Yeah, quality of care is key. And in all these discussions, we should be putting quality of care ahead. And I'm glad there is a bill about quality of care that is still roaming around in Parliament. We need this bill out, because when you talk about quality, then you should follow with the discussion, how do you reimburse for that quality? You can't just talk about quality in isolation. But to answer your question, the quality of care in many facilities has gone down. Because look at a simple thing like the consumables that we have. Examination gloves, for example. Initially, or when cash flow is good, you find that you will want to use when you need.
Yeah.
But when cash flow is low, you would want to save it. You would want to use it only when it is necessary. And when you do that in one item, another item, the third, the fourth, it means that the quality of care itself begins to go down. Yeah, you can imagine if you go to a facility and the same needle or syringe that is pulling
someone's blood,
not even blood, but the drug from a vial, is the same one that I will inject you with.
Oh, stop it. No.
It's not a good thing.
No.
Because once that...
Are you asking us to imagine, or are you telling us what is actually going on?
I'm actually telling you to imagine, and when you imagine, it means it is something that is going. Because if you were to keep on changing that needle every time, that is cost. And this person has come to the hospital, and you have not even been reimbursed the previous visit that they come. Let me give you a good example that is roaming around, and it's happening in many facilities. We have mothers who are coming for the ANC visit.
Yes, antenatal.
Yes. And their previous delivery is not yet paid. So they are now coming for the second round when you are still waiting for the first. So what service will you give this woman? You may want to do your best, but you are incapacitated. Yeah, things like orthopedic cases. These implants that we put on people, they actually bought on cash. No supplier will wait for SHA to pay so that you can pay them. So as a facility, you have to provide. So either you provide or you ask the client to co-pay. Buy for yourself, and then we do the service. Yeah.
And this is information you've shared with the ministry. This is information that, as an association, you've compacted, compiled, and dispersed for.
And it's also public. I think also it's the media.
So
I'm still on
Shudder.
I'm on the needle here, or the vial, whatever it is that you want to call this business, that we have gotten down to that level again.
Sure.
Because if we are talking about having to share a vial that you use to draw blood to then inject medication, we are talking about some serious health risks here, and that we are whittling it down to that there's not payment. So we can't risk using a fresh one because we don't have supply and we don't know if we're going to
increase cost.
Are you kidding me?
Sure, that's it. Look at it also this way. When payment does not come, you also don't have reagents in the lab.
Yeah.
So what happens? You will end up treating this client clinically. Yeah, just, is it headache? Is it this? Is it this? That's how it will go.
And we go to sometimes possible misdiagnosis over a number of things.
Exactly. So that's why we are saying when we talk about the quality of care to the patient, it must work hand in hand with the reimbursement.
So we have a health system that is a health system that is working so hard to exacerbate the conditions and even cause death. Because when you talk about the low quality provision of the care that is needed, contamination could happen, right? 2, misdiagnosis will happen. And of course, you don't get the appropriate care that you should be getting from that facility. And we have an entire ministry that will come up and say 11 billion was lost, and the whole CS cannot find a reason to resign. Have you called for resignation of some of these people as an association?
We've done our part, and we've given our suggestion across. I think personally I've not been here once.
Yes.
Yeah, and these are the same conversation that we have. Even today, I have said you need the tripartite discussion to have things work well, because we can be able to put this thing to each other across the table and help, challenge each other to do better.
Yes.
The only discussion should not be fraud. It is an element. It is an element, but healthcare is not only about fraud. It is an all-round thing. We are still making noise about the level 3s and level 4s that were, denied the right to admit.
Yes.
And when you are denied the right to admit, it means you can't even conduct a delivery, because where will you keep this mother?
Yeah.
You see? So you end up putting a lot of pressure to level 4s and above, because that's where now they have the right to admit. There is still this big question of mismatch, where a facility is, the papers were changed midstream, and you are told you are level 3A and not 3B. You are 3B, not 3A. And that confused the way service is provided. Out of that mismatch issue, first of all, when there is mismatch, the facility is not being paid, because they say that we are
have to
investigating.
wait and figure this out.
Oh, sure. So you see, there are facilities that has gone for months, actually some from November last year, without a single payment, simply because of mismatch. And what is this mismatch? The certificate of registration of a facility is such and such hospital limited. And the limited in the certificate of registration is written in full, limited. But what SHA captured is LTD. That is a reason to keep a facility out.
Oh, Dr.
For real.
Yes,
like,
that's for real. I'm actually giving you examples that are there on the ground.
So based on that, they cannot get authorization for reimbursement or for payment.
And when that happens, there are a number of maternity beds that have been closed. They can't be used. So where are those mothers going in that region? There are a number of beds for medical use, that the medical patients that are not being in use. where are those patients going? They are going to affect other facilities, level 4s and in the other levels that are supposed to be doing other services.
Okay.
It's only that we cannot call for closure of all hospitals.
Yeah.
Because it's, lives depend on that.
Yes.
But I think from what you're saying, it's like we need a thorough surgery on how we manage our healthcare system.
Absolutely.
It is sad because some of the revelations that are coming out today should not be coming out under the 104 billion system. It is much worse to imagine that the quality of care has been relegated to the bare minimum that the attendant can do for you because they need to save costs, because they're incapacitated, because they have not been reimbursed as a facility. And yet here we are, the government is gloating largely, saying that SHA is working. We have 25, 28, 30 million registered Kenyans. And every now and then you hear them saying they're going to curb fraud and they're going to streamline the practice. Mm-hmm. Yet the reality that you're revealing today is appalling. Mm-hmm. I cry for my country because I believe health is one of the things that we should not compromise on. I would urge, just keep speaking up, keep saying what you need to say, keep showing up. And I think every Kenyan bears the responsibility of attempting to save a life, because when you talk about efficiency of a health system, at least we are giving everybody who is ailing a chance to get the proper care that might save a life. You talk of delivery, it's the beginning of life. If facilities are not allowed to admit because of their profiling of where they stand, then mismatch. This mother is forced to go an extra distance to seek ways of copaying, and sometimes complications arise. In the dilly-dallying of making that decision or transferring one person to the next institution, we know we have lost lives. For how long are we going to allow this shambolic, shakable system to continue killing us?
I think I mentioned this as earlier. Say it rises and falls on leadership, because the issues of mismatch, some of them have gone 9 months, going almost a year, and this is something that is administrative, is almost clerical, that somebody can sit down and just make a decision on this. Why it is not being made, you don't understand. Why we are still talking about fraud a year into SHA, and we only have 40 hospitals that have been taken to court, and no single conviction is still something.
Yeah. And let me ask, Doc, and I think this is becoming personal for me.
Yeah.
How do ghost hospitals exist?
That one is a very difficult question for me to answer from a provider point of view. But from how you understand it, is that a hospital is a company or a business that is registered at the registration of business.
Correct.
BRS. And you take that registration to KMPDC. KMPDC, they do their things and issue a license. You move from there, you go to SHA. They empanel you, they give you a contract. That is a very long process for something that doesn't exist to exist.
So when the SHA CES comes out and says ghost hospitals received money, he should be able to substantiate that and say, actually, this is the company, this is the facility, these are the codes, these are the permits, these are the accounts where the money was paid
and they should be able to bring that man to book immediately.
And when you see a flaw in the system whereby you are supposed to have, again, given birth 4 times a year, that's, you know what we are not saying? Is that is money that is being allocated somewhere.
Yeah, sure.
You know, it could seem like, oh, there's a bug in the system and Obed is sitting at his desk, but somebody else has gotten the service. No, that is money that has been siphoned and taken somewhere else.
Exactly.
When you see that a woman has given birth 4 times, that is money that has been taken and sent somewhere else. When someone has had open heart surgery.
And you cannot bring that blame to a provider.
That's the thing I'm asking. Where does this money go? That money? And then also, when Joe has to pay 7,920 shillings, when I have to pay 7,900, when people who go to hospital for care and they're told, okay, well, it's not, if you pay up, then we'll treat you. They pay the 7,920 shillings for a year upfront. That money goes to a pool somewhere, right? Does it then find its way to, what does it do? Does it pay bills? Does it pay what's pending? Or does it keep it in a pool? Where do we know? And if we don't, why? Because it seems like it should be a public piece of information and knowledge that we know that you have paid, so it has gone to the pool. Now go and access.
I wish this seat was occupied by the pair.
Interestingly enough, it was supposed to be. The seat was supposed to be occupied by a SHA official this morning, but that maybe for obvious reasons didn't happen.
Yeah, because those are the questions we receive every day at the hospital. Somebody comes, nimekatwa pesa. I have paid for this service. And you end up, explaining a lot of things. It shouldn't be that way, but I leave that for them. They should answer where the money goes.
This is one of those tough ones where I really hoped that we would get to a place. Even last night, preparing for this, I said maybe we'll get to a place whereby we can then be told that things have been streamlined and they're working a lot better than they were about a year ago. But it's unfortunate that we're here. And leadership, whether you're talking about the leadership at SHA, whether you're talking about the leadership at the Ministry of Health, whether you're talking about the leadership at the top of the country, it all points to this. And we still have to ask questions about where the money goes in a system where people should be able to walk into a facility, get treated based on the fact that they've paid their premiums, and that this is not working. We should then be able to ask why and get an answer immediately. You should be able to get an answer immediately, but that does not happen. And so beyond the sicknesses and the stitches and the coughs and the flus and the cold and the surgeries, the questions that Kenyans have to be asking themselves is that, do we want to be in this situation again tomorrow? And that, can you shut it down, hard stop, and start again? Well, that's what decisions about leadership allow you to do. Decisions about leadership allow you to take a hard stop and say, let's get back into the kitchen, fix this thing, and get people moving on their feet. So beyond it being a SHA question, it's a leadership question, and you want to ask, what are you doing? Dr. Joseph Kariuki, thank you for being here with us this morning. It's unfortunate we had to end on this note, this conversation, but then maybe leaves us in a spot of thought.
Yeah.
Asante sana.
Thank you so much.
Good morning.
This is The Situation Room, the only way to start your day.